ground for all these to happen. So thank you very much for being here with us. I hope you are enjoying the afternoon and Porto for the next one. Please that you will be staying before going to Gaston. Thank you very much. The floor is yours. Thank you very much. Is it? Good afternoon. Thank you very much. Can you hear me?
Yes, I
don't want to stand there.
We have to
Oh, I have to.
our YouTube
Okay.
transmission.
Oh my God. You're going to hold me. Okay, thank you very much. First of all, thank you, Professor Henrik Barros. And uh, let me say this, I am delighted to be here. I am just humbled and privileged to be here among you all. And it's been wonderful 2 days. This is my second day actually over here. Before I start my presentation, I just want to congratulate the student who made the presentation here. He's there? Yeah. Yeah. So I just want to commend you for an amazing presentation what you made. Trust me. This was really good. So just if you don't mind, on my behalf, just a round of applause for him. This is great. You know, you have no clue how good I'm feeling today, sitting and hearing you and listening to your presentation. It makes my day a very special one. So thank you for doing that. I really mean it. Okay. You set the bar very high. I was just telling that we are going to actually ask you to come and give a talk at the University of Memphis about this topic. You have no other choice but to sit. And thank you, Manuel, for a wonderful layout and about CPLP. It was great learning about it. And I think the topics and the issues which you brought up are so relevant and applicable. And especially in this audience. This is a very important audience, you know. So hopefully what I'll do is I'll walk you through a kind of a storyline, if that makes sense. A lived public health experience, and all my lived public health experiences, how it's shaping public health diplomacy and public health in action. I didn't use the word, I was thinking what the title should be. So I don't want to use the word reinvent public health. I use the word reimagine public health. So I just want you to make sure that you keep that in your context and we take it from there. Sounds good? A lot of time the credential, I make my presentation, I always say to describe who I am, why I'm here, and why public health is more important than ever before. And there's a framework that I use, and I like to elaborate on that framework. It's not a 1A, it's a 2A's. So it's a SMART. It's not SMART means 1A, but 2A's. I'll give you two examples. One, how public health in action is taken in public health diplomacy. And then the second area which we are very much talking about is a digitization. We do live in the era of misinformation, disinformation, and all that which is happening. So to me, the Venn diagram, if I have to draw the Venn diagram, I'll draw the Venn diagram of a youth. I'll draw the second circle that is going to be diplomacy. And I'll draw the third, which is going to be technology. So these are the three kind of verticals which I feel public health is going to be shaped as we move forward. So that's all this is all about and the way forward. A lot of time we talk about ourselves, you know, what our credentials are, but I would like you to please see these three things because this is who I am and these are my credentials. Okay. These are driven by my, I was a medical school student and I lost my father when I was in medical school. And I sit, I'm not going to let anybody die. It's very emotional, and that is not the reality, you know. So as a clinician, as a physician, I would see patients. I'm originally from India. I was practicing medicine there, and I would see patients coming in, and I was writing prescriptions. That was not very satisfying to me because I want to prevent. And I said, okay, it's great to do what individual care I can do, but I need to do something on a larger scale, on a more population base. So I describe myself like a person who has a passion to create impact. So this is not a job for me. This is not a 9 to 5 kind of a thing. Deanship, I love it, but what drives me in my role is the passion to create impact. Uh, my father taught me the second thing, that living life with a purpose is a very important element. You must have a purpose. You may be an MPH student, you might be a PhD student, you might be a researcher, practitioner, but you need to have some purpose of why you're what you're doing, right? You came into a discipline for a reason. So living life with a purpose, and giving is a blessing because everybody cannot give. So giving is a very much important blessing. And at that time, I was probably about 19 years of age. I did not understand these three things. I just recalled that, okay, maybe I should do something, but I just don't know what. And today, when I look back, I feel that those are the three principles that have driven me in my professional and my personal journey. So I just want to share that in that context. Sounds good? Yeah. You can stop me, ask me any questions as you want. And if I go over time, you can let me know, because this is, as I said. So as I mentioned, I'm a clinician. I learned evidence-based management, as many of you who are coming from clinical background, that's what we do, patient care. And in 2002, I moved to the US because there was a big stigma during that period of time in India that if you don't go to medical school, then only you're going to do public health. So you have to be like a physician. You can't be just a public health professional. And I chose public health not because I could not do medicine. I chose public health because I believed in public health. So I went to the US in 2002 as an international student with $3,876, one semester loan, and not knowing what to do. This is important. This is also for a lived experience, that how you pack your bag, go somewhere, learn to adjust, adapt, cope, and figure it out what you're going to do. So I went to Boston University School of Public Health, did my master's in public health with epidemiology and biostatistics as my majors. And in 2002, when I went, I had hardly a clue about internet. And as a matter of fact, I never had an email account until I came to the US. If you remember 2002, there was a huge Y2 kind of a thing, and every internet is booming up. Great thing, right? And I went to the Boston University, and the first thing you do as an international student is to find an on-campus job. You have to survive. Survival is the key. So the requirement there was that you must be familiar with use of computers so that you can get a decent enough start. And I'll tell you the context in which I'm talking this. So when I went to the first interview, I said I really need to pay and get a job because I need to pay my rent. And they said, okay, fine. This was an endocrinology lab. So I went there because I have a clinical knowledge. And somebody who was sitting next to me was a computer geek. Believe me, he was doing like this. And I'm watching his hands. How come he doesn't even know which key to press? But there was one gap. He was working in a physician research lab. But every 30 minutes, 45 minutes, he would take the documents and go to a doctor and say, can you tell me what this is all about? Because he would not interpret that. And on that day, I decided that I am going to figure out a unique niche in my career. A person coming with no internet, nothing, goes ahead and then does a PhD in the field of population health informatics. The only person who has a clinical training, a public health training, and a PhD in informatics, which is population based. So what that means is that your limitations and your strengths can always interchangeable. You don't need to say, okay, I'm going to just follow this path and I'm not going to take any risk. Trust me, you need to learn to take risks, but you have to have the belief in that. Okay? So I did my PhD and I was in a medical school as a faculty. I left my job and I went to the College of Engineering and Information Systems. I was the only physician and public health person in the whole university. And the reason I picked that job was some of my friends said, oh, this is a bad decision. This is not a good decision. No, I just want to understand how computer scientists think about health. So for 4.5 years, I was in a School of Engineering and Information Systems and built the first center relation to technology and health outcomes. And what I learned from computer science, because earlier somebody mentioned that we need to have students from all walks of life in public health, whether you're from economics, geography, computer science, information systems. We need people across sectors and across disciplines. If you're going to be limited to just physicians and dentists and nursing, I think it will not really bring the best public health out. So that was a big shift. And the moment I saw that in 2009, I don't know if you're aware, but President Obama passed HITECH Act. That means every hospital facility will have electronic health records. If you don't have that, reimbursement is not happen. And all of a sudden, the field of informatics, wow, everybody wants to become that. So using that evidence into practice through use of technology, I said, I need to be a solution-centric individual. We talk about obesity, we talk about substance abuse, we talk about all public health problems, but people need solutions. They need solutions that work for them. So you need solutions which are sustainable, which are multi-sector. So if I have to ask you, how many of you here do physical activity 7 days a week? None. 5 days? 3 days? Okay, let me reframe the question now. How many of you will do physical activity 7 days a week if you have to pay no tuition? No tuition for any of the things. Education is for free. You have all the liberty, but you have to demonstrate that you will be doing physical activity 7 days a week so that you can stay healthy. A little bit raise more hands. Like that. This is called persuasive medicine. It's a BJ Fogg model of persuasive medicine, which means we always penalize the sick, we never incentivize the healthy. So it's a very different way. So as you age, your insurance premium goes up, right? Mm-hmm. Interestingly, in our model, if you age and if you've been healthy, your insurance premium actually goes down. It does not even stay same. So that means it was a very, very different way of looking at public health as a challenge. Make sense? Yes. Okay. So for you, good with me, right? Okay. You need information that is accessible. Priority for health is not everybody's priority. Somebody's priority is to get a job. Somebody's priority is to graduate. Somebody's priority is to find how to pay the loan. So we have to think about multiple sectors, how they impact. Information has to be accessible. Services has to be accessible. Affordable. I can't tell somebody who's living in a rural setting or an urban slum setting and say, here's an Apple iPhone and you can use this app and take care of yourself. They say, you know what? I don't even know how to do texting. You're telling me to use an Apple iPhone. So we need affordable solutions. Okay. Reimbursable, no matter what we do, we have to show the return on investment of what we're doing. There's nothing free, basically. It's a return on investment. Tailored. Something that works for you may not work for me. Something what works for me may not work for Manuel. So, as you said, CPLP countries, right? They all have different agendas. So, really, if you look at it, please remember this, what I'm saying. This is the premises of the public health diplomacy that has cultivated over the last 13 years of my thinking. Make sense so far? Okay. So I shared this journey with you. I finished off my PhD in 2012. So it's been 10 years. I finished off my PhD in 13, 11, well, 13 years, yeah. So I do a lot of digital health interventions globally. I've worked in about 12 countries in every possible environment you can imagine. So that means global health, sometimes people use the word a lot, global health. It's a great word. I normally don't use word global health. I use word global. It's a globalization because global can be very term that could be very much driven. So the moment you use a vocabulary and terminology, you have to be very careful what vocabulary and terminology you are using. So I use word globalization. So that means uh, anything that has to be done has to connect locally and globally and not just globally. COVID only showed us for the first time that the world is interconnected, but the world was always interconnected. But COVID just highlighted it. Okay. So 12 countries, which means boots on the ground. If I'm going to come and visit Portugal, I'm not going to sit in a hotel and just have a tourist excursion. I will go out. I like to go see things. I will need to know. If I go to Brazil or Nigeria, I need to figure it out, like what's happening there. So those is my experience. My work has been in about 8 different languages, including Portuguese, actually, because my PhD work was done in Brazil.
I only talk in English because of you.
So okay, let me tell you now. If you would speak, I will try to understand slowly. I can't speak, but I can understand what you're saying a little bit. So I got funded through Ministry of Health, Brazil and US Department of Education. So I was in Brazil for about 6 months. Built the largest telehealth program that was Data SUS, integrated the Portuguese data into English. So actually, if you look at the papers, mine was the first paper that brought the Brazilian data into English journal. And I'm very proud of that because they always will say that, okay, I represent Brazil to put that out over there. So I have been still working with them for last 9 years now. 8 multiple languages, smart hubs, $25 million research grants. And the reason this slide is put to you is not to brag about this work. It's to be very humble to show that your limitations are not always your limitations. They can become your very big strengths. So you cannot just say, okay, I don't have this. I don't know whether I should take this. No, don't worry. I have published papers. I developed the first population health informatics program. I'm so delighted for the first public health diplomacy lab that we established in the US. This was very interesting approach because uh, this was not there. My father was an educator and a diplomat, and I lost him. I knew how he was working. I used to learn a lot from him. Uh, and I'll talk about our model for public health education in high schools. And as a representation of ASPPH, I chaired the technology and public health group, and I have traveled about 25 plus countries. So I love to travel to understand the cultural, the contextual relevance of each of the countries. That's a very important element. And I like to travel in places that challenge me, where I find myself more difficult to communicate. And if I don't know the language, I will go there. And that helps a lot because sometimes in a good way, if you have to do public health diplomacy, you don't have to just know the language. You also have to know the hearts and the connection that way. So why public health is more important? There's a changing social, political, cultural, economic norms. This is a big shift which is happening. Emphasis is on more population health and social determinants of health, like housing is a problem, transportation is a problem, basic problems. Health is not the priority sometimes, but it's the basic problems that are driving health now. So if you ask somebody, is transportation an issue or a health an issue? You'll be very surprised. The findings, what they say. They're going to say, I don't have a transportation issue. You're telling me about health. Forget about it. I need to just make sure that my kid goes to the school and I'm able to go to my job. So the changing workforce needs very rapid changes happening in the skills, the knowledge, and the competencies that students need to have today. I use the word localization. Now, as my friend Manuel you mentioned about each country has its own interests, and sometimes those interests drive a lot of things. And imagine within a country there are so many interests. So those also drive different things. So we can't completely rule out local to the global context. So I hope that will help me convince you by the end of this talk that why I'm not using the word global health diplomacy and why I'm using the term public health diplomacy. Okay. Solution-centric approaches are needed. We need ideas, but we also need ideas to implementation. You can't just be stuck to the idea. Okay, and creative leadership, very, very important. Uh, some things I cannot say, but let me say this way. You need to learn to cope. Coping is a very interesting thing. So sometimes you have to know, like, how to respond to what is not known. You need to know that. So that means, does the curriculum teaches you how to cope? That's an important element. And all of a sudden, if public health professionals tomorrow become leaders of public health and they don't know how to cope, they will find themselves in a soup and say, oh my God, I don't know how to react to this or respond to this. Adapt. World is changing, environments are changing, adaptability is a key component. We need to learn how to adapt. Resilient and empathetic are very important. So we need a curriculum that also teaches about resilience and empathy. So these are key importance. I know Pedro mentioned very nicely. He had a great map for this, but broadly, I will say these are the 21st century global health challenges that are out there. There was never a word pandemics before until COVID-19, and now they've started putting pandemics into that. So this is a huge thing which is happening. Conflict is a very big element. We can't expect sustainable development goals to be accomplished if there's conflict happening. So there are these challenges that are critical. Healthcare has to be also fair. It has to be equitable. So it's not just available, it has to be equitable. Expanding access is a critical component. So there was a Healthy People 2030 which said that we need to create social, physical, and economic environments that promote the full potential of health and well-being. Throughout my presentation, I use the word well-being and not just health. Health is sometimes a manifestation of a disease. Well-being is a social, emotional, and also sometimes spiritual aspect of the things. So if a person is more calm or sleeps properly, he or she will be able to better manage their chronic disease. So we have to look public health from a very broad, multi-dimensional lens. So just to give you an idea about what SMART suggested, I was not aware that what I do is actually SMART model, frankly speaking. I was a researcher and I went to one of a very senior researcher and I said, this is how I think. He says, okay, write it down. So I wrote like SMART. He says, what do you mean by S? I says, it's something like we need to create sustainable solutions because everything in my mind was research cannot be just left in the publication and the books. It has to be taken to the community benefit. People should see the benefit of what we do. Multi-sectoral, yeah. When I came as a student, I will tell you honestly, first I'm struggling to pay my student semester loans, then I'm struggling to find a job, then my visa issues, then okay, fine, how do I sustain? So most of the things were driving me. Accessible, how do you reach from your apartment to your place of study? Is it affordable? So all this shaped up from that framework. So this is not somebody like told you, no, it just came and fortunately, I think that this became a kind of way of living smart. What do we do in the smart framework? And I'll show you how we are operationalizing this. So that gives you a sense of that. A lot of time in public health, we gather data, a lot of data we gather. And data has to be gathered three things. It's at multiple levels, it is multiple dimensions, and it is also multifaceted. For example, if you want to improve the health of a population, I think you also need to capture the data in terms of their use of energy and employment opportunities. If they're not employed, they can't be healthy. So we need to link non-health sectors to multiple sectors. Make sense? Information. This is a fundamental basis. If I ask you number 35, what does it mean to you just from your perspective? Number 35. It's nothing. It could be anything. So that means number 35 is data. It's raw. But if I say 35 degrees Celsius or Fahrenheit, that's information. And if I say if temperature is more than 35 degrees Celsius, it's going to be very hot. That's knowledge. So all the principles are, it's not about collecting more data, it's converting the data into information and then converting that information to knowledge. all these principles is exactly what has helped me to come up with public health diplomacy. That's exactly how I use. I said, okay, people are talking about a lot of data, but they interchangeably use the word information, and they're not. That's why you have misinformation, because data could be in any way. You and me going on social media, we are putting out. It's a maybe that's the data. It's a narrative. So we have to first tell people how to delineate between what is data and what is information. That's a so it's a basic aspect of the things on that. So SMART is a human centric. That was my PhD. So I've done my PhD in human centric design. Human centered design means I am not going to tell you what you need. I'm going to co-create with you what you need. So it's co-creation. So co-design of solution. So my PhD, when I was in Brazil, so I asked them like, why don't you publish this? They had the best federally funded telehealth program in the world, but the entire data was in Portuguese. So I called my PhD committee and I said, I have identified my PhD topic. They said, like what? I said, I'm going to convert the state of Pernambuco's data in telehealth from Portuguese to English, and I will connect this data to data source. But this is way beyond PhD work. But I think that's what helped them make decision making on what tele-education programs they need to offer. Huh. So my advisor said, okay, that means you're doing human-centered research. So human-centered research basically means who your user is, what they need, how they need, when they need. And once you have that framework, that will help you to come up with solutions that will work for the people at large. Okay, that's human-centered. Middle out approach. A lot of time we use the word, I'll give you because we are in the context of diplomacy. Global health diplomacy was a term that was very much predominantly done for former credentialed diplomats. So there are 5 arms in diplomacy: trade, planning, but health is not one. Interestingly, health is not one of the arms of diplomats. So you have to have, so that means people who are making decisions for health are non-health and non-equipped with the knowledge of health. So that was global health diplomacy. Then you have a health diplomacy that came out from Geneva. Like it's a great thing, great concept. But to your point, there's a lot of other countries around the world who also have to look at their interests of how it is being shaped. So this was considered a very top-down approach. So if you really look at COVID, diplomats making decisions on supply chain, vaccine distribution, who gets what, but they were not trained in health. So that means the sensitization about what people will need from the health context was missing. And that's where SMART is a middle out approach. What it does, it connects the policy to the community. So what you're doing is you're working at the same time with the policymakers, but you're also bringing the data and the information to educate the community so that they can become advocates. So SMART is a middle out. So at the same time, as much as I'm working with the policymakers, I'm also advocating with the communities. But in most of the environments, either you are working with the policymakers or you're working with the communities. This is kind of a middle out approach. And I'll show you exactly how we are doing this. I'll give you some examples of that. What it does, it connects the voices of the people to the policymakers. When you're sitting on both the sides of the aisle, you also listen to both the sides of the aisle. So you have a better understanding of what the needs are. It is very dynamic and flexible. It's not a rigid platform. And I think you will agree that diplomacy is a very agile, nimble process. It's about consensus building. It's about negotiations. It's also about conflict resolution. It's not always just about consensus. It's also about to have conflict resolutions. So it has to be a dynamic, flexible approach. And it helps solve real problems with real solutions. So if you take this picture, and literally what I did, I put in the center public diplomacy in my mind. And I said, okay, let me see if this can be applied to these principles. Okay. So how do you do this? Now, as I said to you, I've traveled 25 countries. I have done work in Haiti, Nigeria, Brazil, Middle East, India, US. And five things came into the thing that solutions have to be people driven. It has to be because public health is about people, processes, organization. It's not just about policy. It is people, process, organization. You need to come up with research-based solutions and not just research. Because research can be limited to a publication or in the book, but solution can be taken right to the people, and that's where trust comes in. Trust is a very important factor. Innovation, something doesn't work for last 50, 75 years doesn't mean that it's the right thing. That means we need to innovate and find something different. Skill-based education is a key component. And entrepreneurship, something is not working this way, then we need to be a little bit more entrepreneurial and think out of the box. So I use technology. These are my fundamental five pillars, and I apply to community data. And I kept on putting this together, and I said, okay, this is going to be the framework for public health diplomacy. This is how I'm going to shape it. How does it do? I'll give you a very good example of that. I have my own incubator that is in urban slum settings of Delhi. It has expanded significantly. Let me take you an example. It's a process that you can apply to almost anything. The first thing is who your stakeholders are. The stakeholders can be your policymakers, they can be your politicians, they can be people, they can be physicians, they can be community organizations, they can be neighborhood, anything. Everybody is a stakeholder. Who are your community mascots? The way I define community mascots are those people who are kind of voices in the community. People who trust people. Because I can't just walk in and say, okay, here's something you have to take it. And they say, excuse me, who the hell are you? Right? You need somebody who is a voice people trust on it. Then before you do anything and say, here's the program, this is a great program. No, you need to look at all what exists. So that two things it helps you. One, the competitive spirit goes away. It becomes more complementary. Because if I'm going to come and do the same program what you already have, you're going to say, excuse me, I'm not going to work with you. It's a competition. But if I say, I looked at what you are doing, but I can help you make it better, there's a much more receptiveness that you will work with me. Correct? Okay. So inventory of existing programs and policies. If I don't know what exists, then I'm going to just throw out over there, which whatever it is. Then you recruit your community change agents, which means who are your early adopters. So this is a principle of diffusion of innovation. This is a theory of diffusion of innovation. In diffusion of innovation is you have early adopters, you have laggards. Somebody will say, oh, I'm not going to work with him no matter whether he or she does good work. Somebody's going to say, you know what? I think I believe what he's doing. So you need to people have early adopters with you. You understand the community needs now. Then you translate those needs into actually innovation and interventions. You evaluate and create a sustainable plan. Go to the policy, execute from the top down to the bottom up approach, implement the SMART in a framework which talks about the different parameters, whether it's employment, whether it's education, whether it's creation of market, whether it's public health, anything. But this framework is exactly what last 13 years, what I've been using, whether to build an organization, whether to build a concept, whether to build a technology, whether to build a school or whatever it is. So how do we take that, apply to Memphis now? The model of public health education in high schools. We talk about all the conditions about obesity, substance abuse. So if I have to ask you, what would be, from your perspective, one public health challenge in Porto right now? Any?
Only one?
Yeah, number one.
For me, schools.
Schools?
Yes.
Fantastic. And when you say schools,
Teams.
teens. And when you say teens,
Good time on the mobile phone, the food thing.
the food, the social media addiction, the mobile phones, and all that. Sounds good? Correct. Let's say tomorrow you are elected representative for the board. What would your first thing you will do to handle this?
That's the way I feel.
That's a very good way. That's a very good way. You're absolutely right. You're trying to figure out an answer for that, right? So when I went to as a dean, I was very clear that we are not going to make the School of Public Health big. We are not going to make a school that has hundreds of thousands of students. We are going to make it one of the most impactful schools of public health. Impact was the mission. Impact. Okay. So I'm very delighted to share with you that we are the first school of public health in the nation and internationally that has taken public health education and taken to the high schools in a formal credentialed way, which means students in their junior and senior year of grade 11th and 12th can take public health coursework related to social determinants of health, health disparities, informatics, analytics, global health crisis and milestone, public health in action. And basically, these are 15 credits that by the time they come up with high school, they get an undergraduate certificate in public health. Make sense? You want to address the issue of youth? You need to invest in the youth early. Okay. Second, you have chess clubs, robotic clubs. I know Dr. Rafael is here. Like she has been a great partner, and Professor Barros has been here with us. I saw like even my daughter, she goes to high school. I said, okay, she said, Dad, I have a cross country club. Where's public health club? You need a good health and well-being. So you can't let the youth become either obese, become addicted, and then manage it. You need to invest in them early. So we started with public health clubs in the high schools. We are in 16 and we are now in 4 countries. Public Health in Action, I'll share with you. It's an experiential learning initiative. It's now about 14 countries. And we took Public Health Hackathon. I know University of Vienna student participated in our hackathons, and I'm hoping, and I really want the students here participate this year with our hackathon. The first year when we did the hackathon, we had hackathon is like individual and group of individuals come together to solve public health problems. And you challenge them. First year when I went there, they said, oh, 7 students participated. They said, you're coming from New York, this doesn't work. No. This third year, we had 87 participants, 16 teams from 4 continents. Can you imagine high school students communicating with each other from across the world? It's a solution. Let them talk. Give them the tools, the channels, the resources, and let them talk. And they'll figure it out a way that we have not been able to figure it out. But we have to give them the channel and the resources and the platform that guides them in a more objective and not a subjective narrative way. That's the key. Okay. This paper has been published. It's just 2-3 weeks ago, I think. It's based on these pillars. If you look at the pillars, these are called CARES. It's CARES. We teach them how to cope, adapt, be resilient, be entrepreneurial, and how to be successful. So it's not about successful in getting the high school completion. It's about successful in a living lifelong journey. So that principles stay with them for a long time. Okay. So this is our model. This is our hackathon team. We were very amazed to see, and the solutions they come with this. We are also the first school here. If you look at on the other side, students can come at the high school level and can go and complete the doctorate at any level. So, like for example, somebody comes in undergraduate level, they say, I don't have resources to pay. I want to come back. Okay, you can come back after a certain time. You continue. So the goal was really to inbuild public health, institutionalize public health at a very early level. So if you want them to become diplomats, if you want them to become ambassadors, if you want them to become policymakers, they need to know it right early, not later. I brought this program I will tell you, I cannot share my excitement about this program because this is something I really wanted our university, and I'm so glad that they supported us. The students now can get through this undergraduate certificate. They're taught. Can you imagine a grade 11 student now being taught about all these courses? Like they objectivity, They can take care of their own mental health and well-being. They can take care of the mental health and well-being. Oh, grandmom, you need to take this medication. Oh, wow, policy. We are not taking them into the policy decision-making processes. How policies are written, why it is done. So you are really making them advocates of change, but you are not just, don't quote me on this, I'm not saying that activism or not activism, but you are giving them the knowledge and the tools to advocate in the right way with the right data so that they are not getting misinformed. So if I just tell them, okay, go and do it, they're going to go on directionless. But if you guide them, these are the tools with you, and now you can make a decision based on the information that is available to you. They are much better to make that. This is our program, Public Health in Action. This is a high school initiative. We teach this in the form of workshops. This is right now in about 70 plus students, 12 countries. And there was no way we could have reached out. And our partnership is with iEarn Network, which is an international education research network of high school students. And we are slowly, gradually doing, and our mission is about 75 countries by April of 2026. That's where we are trying to go. And the way this is done, each of this has been ingrained with a case scenario and a simulation exercise. So it's not a lecture, but it's a kind of a simulation model that we are creating. Okay, let's say you are representing this country. Yes, how do you make a decision? How do you really, like, of course, this is not based on model WHO or UN, model UN. It has very different context because today public health can be really fragmented and issues that are very critical right now. So hackathon was started. This was something, another second approach. When you tell somebody that this is a challenge, they'll figure it out away themselves. They'll figure it out. You'll be surprised. So I'm inviting all of you, with your permission, to see if you could participate in our hackathon. I know will be a great opportunity. Students, for the first time this time, when they come, they will be enrolled in a course. It's for free. You don't have to pay. It's nothing. It's just we want the youth to connect each other with the right tools and the resources to think about solutions. And for example, students sitting in Memphis can connect with somebody in Nigeria, Uganda, I don't know, Mozambique, and say, wow, the problem which you're seeing is also the problem I'm seeing. What it is doing, it is building a community of learners, practitioners together. These were some of the topics. Address public health challenges. That was our first hackathon. Our second hackathon was public health infodemics in a digital environment among youth. We gave them the second topic. We gave them the third, which is empower youth for digital health and well-being. And I cannot imagine the kind of solutions they came. Based on this work, Memphis City Council passed a citywide resolution on the work that the School of Public Health is doing and encouraging the school students to get engaged in this process. So these are the different students. I know University of Pune is here. Thank you for your support. And I would love to see the Institute of Saudi Public Health over here this time. I hope that can. And all this work in 2024, before elections, I thought that this is the right time to establish the Public Health Diplomacy Lab. And the Public Health Diplomacy Lab was, I have to acknowledge, the University of Memphis supported with the grant funding to come up with this concept and execute this. Our goal was to bring civic society members, academics, and interestingly, there was no diplomacy work that ever came out of from schools of public health. It always came out from schools of international affairs, foreign relations, but public health was never the work that was coming. So the uniqueness of this was that it was coming from public health. That was one. Obviously, I have to acknowledge Dr. Laura Magania, whose support as the president of the Association of Schools and Programs of Public Health. Very strong support of her. I have to acknowledge the support of ASFR, Association of Schools and Programs of Public Health in European region. They have been very supportive of this. And if you really look what I did, I just took the SMART and I've applied to this. And in my earlier listening, I was hearing, you don't need people just from public health. You need people from trade, law, because legal frameworks are critical on how diplomatic efforts work. Intellectual technology transfer, which is a very important element today. Like if you look at COVID-19, it was the intellectual technology transfer that was becoming a challenge. So if you're going to do diplomacy and if you're not getting understanding of these things, then we are shooting ourselves in somewhere like we don't know where we are. Not that we have to be expert in all, but we must have the expertise to use all. Make sense? You don't have to become an international affairs person, but you must know that the international affairs must be at the table. So you need to know who your stakeholders are to be at the table. Okay. Our first inaugural Public Health Diplomacy Summit was done in Memphis. We had 15 countries representing all 7 regional associations around the world. This was probably the largest such gathering that was done in Tennessee from international forum at that level. We had a first publication published out of the summit, actually, so that we want to make sure that we are not just sitting in a room. And as a matter of fact, this was a great event. I think it brought a lot of countries together, different agencies together. And for the first time, the field of public health diplomacy was actually defined with 100% consensus, with people representing different geographic settings. So to me, that is also diplomacy, that we were able to get the definition agreed upon. That's a key component. So you want people who disagree with you also to be at the table. You just don't want only people who are agreeing with you. You must have people with different. We have to have a disagreement, that is perfectly fine, but we have to have a respectful disagreement. That's an important element. Okay. So the definition took almost 3-4 hours of deliberation over a 3-day period. And this is what the definition came out. I will tell you, commas, hyphens, dots, everything went into this, but we were able to successfully get the definition out. And it's effectively communicate. You must know facilitation, negotiation. You need to build consensus. Systems thinking is a very important element. We can't be a singular approach. I can't just say, Manuel, this is only what I want, and I'm not going to give you anything, but you can take anything from me. It doesn't work that way. It has to be kind of a give and take kind of an aspect of understanding. It has to be equity focused, and it has to be human centered values, which means at the end of the day, we are going to support the people who are the recipient of this benefit. These were the 9 points that agreed upon. You are more than welcome to go and look at it. If you look at the number 1 point, Global Public Health Diplomacy Working Group established. Public Health Diplomacy Capacity Building Group, that's what we're doing. Global and region specific learning outcomes, we are in the process. Advanced public by engaging decision makers, I am coming here. I'm going to engaging decision makers. We have created the hub for resources. We have created already that. Organize events. We are already organizing events, participating in events. Analyze and share regions, experience, best practice, and achievement, which means you don't negate, rather you learn from the best practices everybody has to offer. That's a very important element. Expand regional and institutional partnerships. I think we are pretty much well doing that. And disseminate recommendations. I know me and Professor Burrows from here go on Monday, I think, to Gaston, to the meeting there. And a quarterly newsletter was released. It brings all the resources, everything happening. And I would maybe take Pedro your invitation that you should present your perspective in this. This goes out to the entire world right now. So this might be a great voices to be heard about. At the end of the day, it has to be a youth-led kind of a thing. And lastly, I will say a couple of things. This I only picked 3-4 slides, how we are using digital application. And the only reason I picked this project, this was a project that in 2018 was invited by the United Nations to come and present in New York for me. You've heard the Sustainable Development Goals, SDG goals. There was no SDG data collection happening in urban slums, primary data collection. So we did this project, brought in 40 slums, did some work in Brazil, some work in India. And all of a sudden we went there and the invitation came to present this. For the first time, the urban slum dashboard was prepared on employment, energy, electricity, people looking at disability care, like all kind of data. And that was helping us shape policies with the government policymakers. This has now been expanded to about 6 states around the different parts. This is a health ATM. I want to show you. Remember, people want solutions. So the health ATM works in a very simple way. People say, oh, access to care is very difficult. I don't want to go to a physician because sometimes it can become very expensive for me. But there are people who are out in the community who are going with hypertension, with diabetes, but they don't want to go to a doctor unless they see. So very simple thing. This thing, like a computer like this, Windows 95. Windows 95. $150 has blood pressure, blood weight, and blood sugar attached. If you have no literacy, it speaks in English, Hindi, multiple languages. There are now 9, 10 languages. We are going now in Arabic language, Portuguese, Spanish, multiple languages. People walk in, they use it, and a health card is generated that tells them which list they are. So it's a self-management plan, which is chilling. How does it change? It pushed the government policymakers to incorporate this into a public program. So that means people lead. You show, they made a policy. That's all. So we did not leave this to just research. The last slide out here is a smart rapid tracker. I do want to bring this slide up because this was an effort of about hundreds of students from all over the world. If you remember, when COVID happened, everybody was citing Johns Hopkins tracker, right? And New York Times. But there were many countries around the world with almost no resources who had no tracker of their own, no centralized tracker. So approximately 130 interns we had who came all together, and we built the first policy informatics platform of COVID that linked every single country around the world. So if you want to see something in Brazil, you could see the tracker. And if you want Portugal, you could see that. If you want to see Uganda, you could see. So everything was created by this. And that showed how the power of collective impact can come together. And this actually, which started from COVID-19, has now become a pandemic decision support system. A small thing. What was the investment? Investment of commitment, time, passion, no resource. No resource. It's a product of zero funding. Zero funding. But who is the beneficiary of this? Entire world. So we made it public. You will see so many papers published out of this thing. And we are continuously managing it, and we've created the whole policy platform around this. So you can look at every country, you can look at state comparisons, you can even go to the health plan centers, labs, everything in one platform. $0. Okay. This is the New York platform. I'm showing you just different flavors. One was in Brazil and in India. This was in the United States. This platform is for, you can track the burden of HIV in New York State, right? And this is called advocacy. Because now people can see what is actually happening. They can connect with it. This is the entire sub-Saharan African countries are connected through this platform. This is a first French dashboard that connects all HIV population in all the different African regions. Once you start creating these kind of tools, it manifests questions and more objectivity. And last, people say, okay, how do you measure impact? The measure of impact is at 4 levels. It's at a social level. How many people we are giving skills, literacy, awareness, and practices? How many jobs have been created with this platform? How approach income is there? What preventive practices? So this is kind of an impact that is measured through this process. And if you really look at public health diplomacy, to be very frank, I would measure public health diplomacy. I will measure it at a social level, at an economic level, at a health level, and at a data level. Lastly, we need global, as I said. I highly recommend that systems thinking, creative leadership, human-centered design, innovation and entrepreneurial and evidence-informed information are critical competencies today that are needed in the workforce. There's a very, very important area. We must have creative leadership and not just leadership. Way forward, only couple of bullet points for you. Public health innovation is a very important. We need to create cost-effective solutions that work for all. It cannot be expensive solution. We can't just have that. There is a enormous gap in public health innovation. As a matter of fact, even at ASPPH level, public health innovation and entrepreneurship is not a core competency even yet. So we must incorporate that competency. There is a need to collaborate, higher education institutions, CPLA. I'm so glad that you're here because this is a great opportunity for students to learn how to facilitate this process. We need, as I mentioned to you, more training programs that have diplomacy as a critical core competency. Lastly, this has never come easy. It was not easy. It's not going to be easy. This is, I always say, obstruction is opportunity. Innovation has been a struggle, but we can continue. You go on. I'll conclude by one statement I shared earlier during our lunch, and I never end my statement until I use one word of wisdom from my father. He said that grow like an old tree. An old tree does not grow vertical; it grows horizontal, which means with success, be humble so that you can give shelter to many. So one of the things in public health diplomacy, it's not a textbook, it's not just my philosophy, is when you go and meet with anybody or go and discuss any initiatives or anyway, go with no expectations. When you go with expectations, you might get dejection. If you're going with no expectation, the one thing for sure will be that you will be very fulfilling because you never thought about what it is. I think diplomacy has become very transactional. And where public health can contribute is move it away from being a transactional thing to create a more reinforcing message that public health is for good health and well-being for all. There could be some areas, but when we come into the room with different hats, different disagreements, we must leave everything behind and just make sure one thing, that we have a one common platform and an agenda to make good health and well-being for all. That's where I would like to end. Thank you very much for your time. And sorry if I took.
Thank you, Ash. I think I have time and actually some pressing questions. You're ready.
Thank you, Doctor, for the wonderful presentation. My question is focused on something you presented in the beginning that we also have been discussing here, which